Okay, and I would like to introduce our next speaker. So I have the pleasure to introduce Lisa Catalli, who's a nurse practitioner at UCSF at the Department of GI and Hepatology. She's been treating Hep C since the dawn of direct-acting antiviral therapy and has been a co-investigator in several multi-center Hep C clinical trials. Her expertise in treatment has led to multiple educational and leadership activities in Hep C elimination. She's also a key clinical faculty at the UCSF Project ECHO program, which uses multi-point video conferencing to build knowledge sharing networks with community providers to build the capacity for Hep C care in rural settings. Lisa has worked to disseminate knowledge about Hep C through mentoring and teaching students at UCSF School of Nursing. So we are excited to have you present, Lisa, on Hep C in special populations. And the virtual stage is all yours.
Wow, thank you so much. It's an honor to be able to present for this conference. It's really great. And I would like to thank the organizers for inviting me. So I'll be talking about Hep C in special populations. I have nothing to disclose. So the objectives of this talk are to review the most recent guidance for the management of some special Hep C populations, highlighting the simplified HCV treatment algorithm and pan-genotypic DAA regimens. I'll also be reviewing guidance from societies in the management of kidney or liver transplant candidates and how that intersects with the timing of HCV treatment. And finally, we'll be exploring considerations for the treatment of some complex patients with Hep C in decompensated cirrhosis and known HCC in the form of clinical scenarios. So given the high safety and efficacy of DAAs now covering all genotypes, treatment has become as short as 8 weeks in duration, even in patients with compensated cirrhosis with high SVR of 95% or greater. There's been a very strong movement toward a simplified HCV treatment algorithm for primary care providers, really emphasizing simple, non-invasive fibrosis staging tools to minimize the barriers to treatment. And there's been a big emphasis as well on test and treat strategy with a goal to decrease the incidence and prevalence in the population, really to reach HCV elimination goals by 2030. So the simplified HCV algorithm, who qualifies for that? So adults without cirrhosis, treatment naive of any genotype, or adults with compensated cirrhosis, treatment naive of any genotype, with the caveat that for genotype 3 patients, NS5A RAS testing should be done to determine if Y93H is present if you need to use soft velpatosphere. Patients who are not eligible for the simplified algorithm are anybody with experience in Hep C treatment previously, of course, decompensated patients, patients with co-infection with HIV or Hep B requiring more additional monitoring. Also, DAAs are not currently recommended in pregnancy, although studies are underway, and known or suspected HCC, which we'll be talking about, as well as prior liver transplantation. So here are all of the current FDA approved direct-acting antivirals. Just to refresh your memory, we have the protease inhibitors listed here, NS5B inhibitor, there's one NS5B inhibitor and several NS5A inhibitors. And these are the corresponding trade names and the genotypes that they cover. And note that the first 4 rows are the first line regimens, whereas the last row, Vasevi, is the second line, generally the second line regimen used for DAA failures. And the simplified treatment algorithm regimens are the pan-genotypic regimens, the first line pan-genotypic regimen, soft velpatosphere, or what we'll call soft vel, or glecaprevir parentosphere, which I can never say very well, and we'll call that GP, and that's for 8 weeks. And I'd really like to highlight that 8 weeks of GP is sufficient for all genotypes in patients with compensated cirrhosis who are naive to prior treatment. Even the harder to treat genotype 3 patients who early in the DAA era were still a little bit more difficult to treat. As long as they're treatment naive and compensated cirrhosis, they have an efficacy. This regimen has an efficacy of 95% or greater, and there's no need for baseline RAS testing. Now let's take a look at a special population that used to be managed differently. That's acute Hep C. Previously, the guidelines used to recommend waiting for a 6-month period to determine whether spontaneous clearance of HCV would occur, which was about 20 to 50% of cases. Now, the AASLD guidelines emphasize this importance of a test and treat strategy, or really just treating Hep C upon initial diagnosis, like I said, to reduce the incidence and prevalence in the population and also reduce transmission. And with regards to treatment, you would treat acute hepatitis C like chronic hepatitis C, but know that emerging data on shortened courses of DAAs in acute Hep C will be coming forward, but currently shorter durations are not sufficient. The data is not currently sufficient to recommend that at this time. So another important population is renal disease, hepatitis C and renal disease. The prevalence of Hep C in CKD and in patients on dialysis is quite high, and routine screening is recommended in hemodialysis patients. The KDIGO guidelines recommend that all patients with CKD who are infected with Hep C be evaluated for antiviral therapy, as Hep C cure will improve clinical outcomes in patients with renal disease. So let's take a look at a clinical scenario now with renal disease and Hep C. You have a 60-year-old gentleman with CKD stage 4, genotype 3, treatment naive, referred by nephrology. The etiology of his kidney disease is MPGN, which is likely an extrahepatic manifestation of Hep C. He's HIV negative, also Hep B negative, and he's immune to hepatitis B. His FIB4 and APRI both estimate the absence of cirrhosis, and his nephrologist would like you to treat him potentially to improve his kidney function. So what are his treatment options? So currently, in this patient with CKD stage 4, genotype 3, treatment naive and non-cirrhotic, SOF-VEL and GP are both the recommended regimens for this patient. Previously, not long ago, GP would have been the only recommended regimen and that would have been for an 8-week duration. And this was due to concerns for an active sofosbuvir metabolite excreted in the urine, raising concerns for SOF-based treatment in patients with creatinine clearance of less than 30. However, the label now indicates that no dose adjustments are needed for SOF-based treatment in moderate to severe renal impairment. So the change in the sofosbuvir label is based on this analysis of a prospective cohort of over 2,400 patients with mild to severe CKD treated with SOF-based treatment and without a non-SOF-based treatment, and showed that the risk of progression to end-stage renal disease was not different in the two groups. And similar results were observed when stratified by CKD stage. Now, what if your patient had been on dialysis for the past 5 years and is listed for kidney transplant without a potential living donor? For patients who are on the deceased kidney transplant list, the KDIGO guidelines recommend that we consider the anticipated wait time to transplant and whether organs from hepatitis C positive donors are available to decrease that waiting time. So if the patient is willing to consider this option, a Hep C positive kidney donor, deferring treatment until after transplant is an excellent option for that patient and can substantially reduce his waiting time in our region in Northern California to about a year, actually. So now let's talk about, I'm going to shift focus to the management of another important population, patients with HCV cirrhosis. And we'll do this through another clinical scenario of a 57-year-old woman with genotype 1A, treatment naive, radiologic evidence of cirrhosis. Her past medical history is positive for hypertension and GERD. She has a history of alcohol use disorder. She's been abstinent for a year, And she has a 20-pack year history also of tobacco use and has quit also 1 year ago. She complains of forgetfulness, sleep reversal. She does have lower extremity edema, but no history of ascites or any history of GI bleed as well. She's on 2 antihypertensive medicines. She's on Lasix, spironolactone, omeprazole, and lactulose. And her ultrasound shows a nodular liver splenomegaly and no focal lesion or ascites. So in patients with known cirrhosis, it's important to determine the severity of cirrhosis by calculating the child's Pew score, because it's going to guide the DAA treatment decisions. And of course, we also need to calculate the MELD score in a cirrhotic patient if we're considering a referral for liver transplant. So on the right here, you can see the baseline laboratory studies. You can see a normal bilirubin and INR, but she has a low albumin, and her calculated child's Pew score is actually 7, and she's child's Pew B. And her MELD score is also a 7, so she's of low priority for liver transplant listing. And given her low MELD score of 7, you proceed with recommending treatment, and you counsel the patient that you can reduce the risk of her developing HCC in the future by about 70% once she clears her hepatitis C. So that's a huge benefit. And she can also possibly have clinical benefit with improvement in her overall symptoms and stabilization of her liver disease. So this is an online decision-making tool for decompensated patients. It's called the BE3A scoring system to estimate the likelihood of recompensation to child's Pew A after HCV cure. The tool uses a 5-factor metric of BMI, encephalopathy, ascites, albumin, and ALT level, and it calculates the probability of achieving child's Pew A status. This tool was developed through a retrospective analysis from 4 trials on the effects of sofosbuvir-based therapies on patients with decompensated cirrhosis and following them for a period of 3 years after cure. So this is a very helpful tool sometimes. So what are her available treatment options for this patient? She's decompensated and she has genotype 1A. Well, because she is decompensated, she's actually not eligible for PI-containing regimens, given the increased risk for worsening decompensation. Therefore, given her genotype, she would qualify for either soft lidiposphere or soft valpadosphere. And the guidelines, ASLD guidelines recommend adding ribavirin, back to ribavirin again, to the DAA regimen for decompensated patients, and treating for a duration of 12 weeks. However, for patients who are not eligible for ribavirin due to adverse effects or comorbidities, recommendation is to extend the treatment to 24 weeks. So why is ribavirin recommended in decompensated cirrhotic patients? The recommendation to add ribavirin are based on real-world studies, as well as clinical trials like this, showing higher response to DAAs when ribavirin was added. So in this phase 3 clinical trial study, patients with child's B were randomized to soft-vel for 12 weeks, soft-vel ribavirin for 12 weeks, and soft-vel for 24 weeks. And you can see here the overall SVR was highest in the ribavirin arm, that's the red arm. And for genotype 1, the difference between the ribavirin arm and the soft-vel 24-week arm is not so significant. But take a look at genotype 3. The most marked impact of ribavirin was in patients with this genotype. And ribavirin is very important in genotype 3 and can overall increase SVR. So as Dr. Sai had alluded to earlier, the ribavirin is known to be associated with some side effects, and frequent laboratory monitoring is needed due to hemolytic anemia. Now, because your patient has known cardiovascular risk factors, in this case, she's hypertensive, she's on medications, and she also has significant tobacco use, a baseline cardiac stress test would be recommended to rule out underlying CAD. And also remember that ribavirin is renally cleared. Therefore, patients with renal impairment may experience more hemolysis, so the dose should be titrated appropriately. And the other side effects here listed here can make ribavirin quite difficult to tolerate, and it is a serious teratogen. Therefore, pregnancy should be avoided within 6 months of treatment, and preferably actually within 1 year of discontinuing ribavirin. Now let's consider another clinical scenario. Let's say your patient had ascites with a higher MELD. So you can see here she has ascites on imaging, and she has impaired liver synthetic function with a creatinine of 1.2. And her calculated Child-Pugh is C now with a MELD sodium of 19. So now what do? So considering her MELD of greater than 15 with significant portal hypertensive complications, you are not sure if you will be able to achieve clinical benefit from HCV eradication in this patient. And she may be better served by getting a liver transplant, or at least being evaluated to determine her options. So in this case, you would defer DAA therapy for now and prioritize liver transplant listing. HCV treatment in decompensated liver transplant candidates should be individualized. And the key question to ask when you're evaluating a patient with decompensated cirrhosis is, will the patient achieve clinical benefit from HCV eradication to decrease the risk for liver-related death or need for transplant? The treatment goals for decompensated patients include stabilization of their liver disease, improving quality of life, preventing the need for transplant, and preventing death. So you really want to treat selectively and in an individualized fashion, considering the anticipated time to transplant as well as access to a living donor. So let's look at predictors of transplant delisting after HCV cure. This was a retrospective study that followed patients after they were cured of Hep C, and found that when their MELD scores at the time of DAA therapy was less than 16, almost 90% had a significant improvement in their MELD score, resulting in a 50% chance of delisting or no longer needing a transplant. If MELD score was higher, especially in the 20 range, then that risk, the chance of delisting was reduced to as low as 15%. So this study really highlights that patients with higher MELD scores, particularly in the 20 or above range, may benefit from deferring treatment until after transplant. And now we're going to discuss another special population, patients with hepatocellular carcinoma, through another clinical scenario that illustrates some complex decision-making regarding the timing of DAA therapy. So this is a 65-year-old man with a new HCC. He has genotype 3, compensated cirrhosis with a MELD of 10. Prior to initiating treatment, you recommend abdominal imaging to rule out HCC, and an abdominal ultrasound shows a suspicious lesion, and a quad phase CT scan characterizes the lesion as a 2.7 centimeter LR-RADS5 lesion compatible with HCC. So the question now is, do you proceed with HCV treatment now? So two important questions have arisen in the era of DAAs in patients with active HCC. The first question being, is there a higher risk of HCC recurrence with DAAs in the presence of HCC? Initial uncontrolled studies early in the DAA era had suggested a higher rate of HCC recurrence after curative treatment with DAAs, but then subsequent retrospective and prospective controlled studies then refuted this finding. However, given the unknown effects of rapid HCV clearance on immune surveillance, this question still remains a bit debatable. The second question is does the presence of HCC affect the efficacy of DAAs? And I'll show you over the next couple slides that studies have shown that this is likely, actually. So you can see from this retrospective study of over 400 patients with active HCC at the time of DAA therapy, The presence of HCC was found to be a predictor of treatment failure, with a 20% reduction in SVR, that's the dark blue arm here, and an 8-fold risk of failing DAA HCV treatment. In regards to patients with HCC who are transplant candidates, this large cohort study of over 17,000 patients in the VA system with and without HCC showed a similar reduction in SVR by about 20%. The light blue line being, the light blue bar being those without HCC, and the royal blue arm here is with HCC. But note that in patients who deferred DAA treatments until after transplant, that's in the dark blue arm, they had a much higher SVR after transplant at a rate of 95%. Therefore, the takeaway from this study is that listed patients with HCC who are likely to receive an organ offer soon may benefit from postponing DAA therapy until after transplant. Now, what about patients who would benefit from DAA therapy prior to curative treatment of HCC? The HCV Target Consortium study sought to answer this question and demonstrated a 50% lower odds of SVR in the presence of hepatocellular carcinoma. As you can see in the bar graph here to the left, the patients without HCC had a higher SVR compared to patients with HCC in the second two arms. But it also showed that the efficacy of the DAAs was only 9% different than the first arm. And that was probably related, most likely related to the study period, like up to the more potent DAA regimens in this study period. But it also showed that whether the HCC was treated prior to DAA therapy or untreated or only partially treated prior to DAA therapy, it did not matter. The SVR was about the same. So the takeaway from this study is there is no need to delay DAA therapy for patients with active HCC who would benefit from HCV eradication. And this is especially true for decompensated patients who can have stabilization of their liver disease with HCV clearance and more curative options for hepatocellular carcinoma. And finally, I'll highlight this multi-center cohort study, which found that DAA therapy is associated with improved survival in patients with HCC. There was a 50% lower risk of death in patients who were treated with DAAs who had complete radiologic response to HCC treatment prior to the initiation of DAAs. So back to our 65-year-old gentleman with active hepatocellular carcinoma, you can see that it poses some complex decision-making with regards to the timing of DAA therapy. Since he seems to be a reasonable candidate for liver transplant, you defer DAA treatment and refer to him to a transplant center, as he can also consider whether an HCV donor, HCV positive donor, will significantly decrease his waiting time. So in general, in patients with hepatocellular carcinoma, the HCC should be prioritized as it is most likely to affect long-term outcomes. If in patients with compensated cirrhosis, we generally would defer DAA therapy until a response to curative HCC treatment is known. In decompensated cirrhosis, however, DAA therapy should be pursued with a goal to stabilize the liver disease so that the patient can have more curative options for HCC and to improve overall survival as well. So in conclusion, the key points are that most patients can be safely and easily treated with DAAs, even in patients with severe renal impairment, and no dose adjustments are needed. And for kidney transplant candidates, consider HCV positive kidney option to reduce patients' wait time to kidney transplant. In patients with decompensated cirrhosis, they have limited treatment options for DAAs, and the timing of DAA therapy in these patients really poses challenges when we're considering liver transplant versus the stabilization of their liver disease. And finally, if HCC is known or suspected, the general rule is to prioritize the HCC first and then to address the HCV. And that is, I can stop my share, and if there are any questions.
Thank you, Lisa.
Thank you.
That was great. I really enjoyed the case studies that you presented. Lisa, I did have one question I wanted to ask. Lately we've been using, with the Harvoni and Epclusa for the Hep C treatment, and majority of our patients, I work with a liver transplant patients, so not more so on the outpatient or with the Hep C patients, but we don't use ribavirin on those patients. So I saw in your one of your case studies, you did mention that you do add that.
Yes, and that was for the decompensated patients. Are your patients decompensated?
Oh, no, these are like the post. So
yeah.
Okay.
For post-transplant. Oh yeah, we used to treat with ribavirin in post-transplant, but now we found that the SVR was the same with or without ribavirin. So we are not treating with and we're treating either with soft valpadosphere or GP, but also with Harvoni. But it usually in our transplant recipients, we're treating with pangenotypic regimens.
Got it. So I just wanted to clear that.
Yeah.
See if there was any. There was one question. Actually, there's a couple questions. Is there any concern for worsened clinical disease from Hep C in patients on checkpoint inhibitors for HCC?
Worsened clinic disease from so worsening. So you're saying that more they're more immunosuppressed. So that's a good question. I'd like to open that up to one of the Mindy, Dr. Nguyen or Dr. Tsai, if you know, because I actually don't know. Probably Dr. Nguyen.
Yeah. Oh, Dr. Nguyen wants to say something. Yes, go ahead.
I want to make a comment on the HCC treatment issue, but before that, in terms of HCV reactivation, I'm just sharing this, but I think many of us may have the similar experience. Dr. Zai it's different from Hep B. Hep B has very nasty reactivation, but not Hep C. I have seen many people refer to me worrying about that, for chemo and all sorts of stuff. But, usually the viral load can go very high during immunosuppression, but they actually don't have like the hepatitis flare like hepatitis B. So in general, we don't preempt it. Now we have DAA, which is pretty easy to treat, so if we can treat, we treat anyway, but not because we are afraid of the reactivation. And I wanted to make a comment about the treatment of HCC and HCV, because I think this is a very important topic. So besides the paper the study that Lisa showed, there have been other, large studies to clearly show that DAA treatment really significantly improved survival. So if you can think about it, in one of our studies on this, we actually found an 18-month on average survival. And we are all excited about sorafenib and some of these new systemic treatment that only increased by 3-4 months. And this increased by 18 months, median survival. So I really think that we would do our patients a disservice if we hesitate to treat these patients, no matter how, advanced, they are. Now, I don't know if I agree with that the treatment, the response rate is reduced in HCC regardless of HCC treatment status. I don't think I would agree with that. So I know that study from Target, but if you look at it, there's only 60 something patients in one HCC group and only 90 in another group. So we did a systematic review and meta-analysis of the world literature on this. And it's clearly show that if we put everybody together, then the rate seems to be a little reduced. But if we did some analysis of the people who are active HCC and non-active HCC, the non-active HCC, the rate is about the same in the 90% range. And the active HCC group, it was in the 70% range, which looks low because a lot of these people also have decompensated liver disease. So we we published last year a study on 500 HCC and more than 6,000 non-HCC patients. So we were able to do propensity score matching, and we clearly show that in active HCC and non-HCC exactly the same, 94%, after we adjusted for all kinds of stuff. And then the active HCC did have a reduced rate, but it was still a respectable 85%. So I think that, I think that if the patient can get HCC treatment first, then we should treat the HCC first and then the HCV after, so that we can maximize the response. But I have had a few patients, their liver function is borderline, so people are afraid to send them to TASE or treat them. So in those patients, if we treat them with with HCV, then, after 2-3 months, their liver function improves, then they can tolerate HCC treatment. So I think that, DAA treatment could be a lifesaver for our HCC patients. And I know there are groups that really, emphasize the downside of DAA and HCC, but I think that those are not very well evidenced. Now, you may have also heard about the increase in recurrence, like the Barcelona group reported this a few years ago. But then since then, there have been very good studies that clearly show that it does not increase in much larger and well-controlled studies. So I want to do away with all these myths about it.
I would agree with Mindy, because really the reactivation or increased activity of hepatitis C with the treatments for cancer is not really that much difference if you are looking at the response rate. And then in allude to the target study, that the variables that they used was not really like Mindy was talking about. When you look at different variables, the disease stage of the liver, the genotype, it was not in there. It's kind of lumped together. And so that is much difficult to really come with, say, summary conclusions that is good or better, because you really have to be fine-tuning of what patient that you're dealing with. And of course, more compensated disease the patient have with HCC, the better response they are. And so I think that's something that when you're treating those patients should be taken into consideration. But going back to Dr. Holt's questions, that would you worry about, particularly your checkpoint inhibitors, not other, but checkpoint inhibitors, would they have problem with immune reactivation? The answer probably is not, but there are reports of checkpoint inhibitors hepatotoxicities. I think that may be something you want to look out for.
Well, thank you so much, everyone, for your presentations, for coming here on Thursday night, and for the lively discussion. To be honest, this was my biggest concern, that we were just going to be a bunch of talking heads and we were going to bore everyone to death. So I was so excited to see a very lively discussion in the end. Thank you so much for that. Let's see. We are very much looking forward to you joining us next Thursday for the discussion on hepatology in the age of COVID-19. We're going to have Dr. Julius Wilder talking about practicing hepatology during the pandemic. We are going to have Dr. Renu Dhanasarkar talking about the impact of COVID of liver disease. And we will have Dr. Oren Fix talking about management of COVID patients who are on immunosuppression. So this is an exciting lineup, and we certainly hope to see you all on Thursday.